All right, so my name is Rachel Kadar, and today we're going to be talking about ultrasound in the intensive care unit, hypovolemia, and more specifically, we will talk about ultrasound assessment of volume status and hemodynamic parameters. I have no financial disclosures. So as we work through our lectures, we are looking at a goal-directed echo, and I'm oftentimes arranging my lectures on the 5 assessments in shock for goal-directed echo. So what am I looking at? Left ventricular size and function, right ventricular size and function, pericardial effusion, or more importantly, tamponade, intravascular volume status, and gross valvular abnormalities. And today we're going to talk about intravascular volume status. So when we talk about volume status, we're going to talk about shock and the assessment of volume status as it relates to the reason our patient's hypotensive. And we're going to talk about the inferior vena cava and ultrasound of the inferior vena cava. And when we do this ultrasound, we're going to have 2 separate ways that we're evaluating the IVC with the ultrasound. And one is going to be estimating CVP or central venous pressure. The other is going to be evaluating fluid responsiveness. And so those are 2 different sets of literature and 2 different questions we're asking when we use the ultrasound to take a look at our patient's IVC. We will then move on to talk about hemodynamic measurements. So we'll estimate PA systolic pressure by ultrasound, and then we'll end with talking a little bit about left ventricular end diastolic volume as a marker of preload. So this is a chart that shows the shock state and how we might identify it based on pulmonary artery catheter with hemodynamic parameters. And so the normal values are in parentheses. You can see here the shock states. Hypovolemia, we have a decreased CVP, decreased PA pressure, decreased cardiac index. Cardiogenic or left heart failure, we have an increased CVP, increased PA pressure with a decreased cardiac index. Obstructive right heart, you might see increased CVP and decreased PA pressure depending. Distributive early or late, we would see decreased CVP and PA pressures most likely, and then increase or decrease cardiac index depending on the time of the shock. In the last lecture, we talked about how we can use ultrasound to determine cardiac output, or what would kind of be here in this cardiac index. And today we're going to talk about how we can use ultrasound to determine CVP and PA pressures. And so now that we can gather a lot of the information that you would get on a PA catheter non-invasively from ultrasound, it just gives us another reason that ultrasound can help us in leading to our differential diagnosis in shock. So the assessment of volume status, we've all seen this Frank-Starling curve, and it shows here how an increase in preload will affect the stroke volume. So you have on the y-axis stroke volume, on the x-axis is your preload or your left ventricular end diastolic volume. And you can see here on the purple line that if we are here at this end of the curve, if you get an increase in fluid bolus, you will get a significant response to that fluid bolus or increase in stroke volume. Versus if you're up here on the curve, you have that same increase in preload or same fluid bolus, but you don't get nearly as significant response in left ventricular stroke volume or output. Same thing if you have a decreased ventricular function. A lot of people will say, oh, I didn't give them any fluid in the ED because they have a decreased ejection fraction. Well, that's not necessarily true, because if they're here on the Starling curve, we might not get as significant as an increase in stroke volume if we would get if they had normal ventricular function. But if this patient is intravascularly volume depleted, even if they have a decreased ventricular function, right, we can give them a fluid bolus and we will still get an increase in stroke volume. Versus if we're over here at the end of the curve, we might get that same increase in fluid bolus and an even smaller increase in stroke volume. We may turn to the point where our volume is hurting our patients. And so this is why it's very important to know where you are on this curve. And that's what we're going to talk about today. Over here on the right, you have a list of all the other ways that we kind of look at volume status and central venous pressure, PA catheter, lactate, stroke volume variation, pulse pressure variation, passive leg raise, IVC ultrasound, we'll talk today, and then pulse contour analysis as well. So when we talked about inferior vena cava use or IVC use, again, I said there are 2 things we're going to be looking at. So estimation of CVP or central venous pressure and prediction of fluid responsiveness. And I want to kind of stress that these are two different ways of evaluating. So the top estimation of CVP, this is an echocardiography measurement. So if you look at an echo report, you will always see the IVC or the right atrial pressure, or maybe not always, most of the time, right? And this is done in spontaneously breathing patients. So if the patient's intubated, that report might say unable to calculate CVP or right atrial pressure because the patient's intubated. And that's just because the literature isn't supported in intubated patients. And then prediction of fluid responsiveness, I like to have three key takeaways. I often use IVC diameter in looking at this. And if the IVC diameter is less than 1.5, this patient's likely going to be fluid responsive. Now, if the patient is intubated or ventilated, and we want to look at an equation, we would look at IVC distensibility, which we'll talk more about later. If the patient is spontaneously breathing, we will look at IVC collapsibility. So how do we do an IVC ultrasound? It's going to be subcostal right here, indicator towards the patient's head. So we've kind of rotated from our subcostal 4-chamber view to where that indicator is going to the patient's head. We're getting that IVC in long axis view, so it should look like a nice tube. And if you see the aorta, the IVC is usually parallel and right next to it. So you can usually do a tilt to kind of get that IVC into view. I like to use the phased array or cardiac probe. You may see some people using an abdominal probe, which is fine. But I think the phased array is the best for it. Here we should see the IVC dumping into the right atrium. And ideally, you also see this left hepatic vein coming down as well into the IVC. We should see liver on both sides. That will help tell us that it is, in fact, the IVC and not the aorta. When we measure the IVC, again, this is a subcostal or subxiphoid long axis view of the IVC. So it'll look like a nice tube dumping into the right atrium. We want to make sure we measure it perpendicular to the long axis of the IVC. So if I put M mode or motion mode across this and my motion came down like this, as we'll talk about in the next slide, it would actually not be totally perpendicular to it. So my measurement might not be as accurate. We're going to measure just caudal to the left hepatic vein. So here in this picture, here's the left hepatic vein coming down, and we're going to move this way just a little bit. So here it is. And I generally say it's about 1 to 2 centimeters from the right atrium. If you are too far from the right atrium, there is concern that you might be underestimating the IVC or just that it might not be as accurate. So we really want to note, ideally, we see this entrance into the right atrium so that we can know where to measure the IVC. If you're doing M mode, which when we talk about IVC distensibility and collapsibility, we might want a minimum and a maximum diameter, and M mode or motion mode is the easiest to do that. So let's review again what M mode is. It's motion mode. So this is motion over time. So motion here on our x-axis, on our y-axis. Time is on the x-axis, and here's this slice of ultrasound through here. So this part here at the top, this is the liver, this black or anechoic area right here, right? That's the IVC. And you would put M mode or motion mode across the IVC and you get a maximum and then a minimum diameter. Here you can tell that there's not a significant difference between the maximum and the minimum, showing that there's not a lot of respiratory variation, which we'll talk about. And then also of note, when you do M mode, this is that preferred angle. So in some instances, you might not be lined up as appropriately. So another reason why maybe doing a calculation is not as easy as just kind of qualitatively assessing the IVC, which is what we'll talk about. So overall, when I do an IVC ultrasound, I'm kind of getting a general gestalt of what do I think their volume status? And that question I'm asking is it fat or is it flat? Because generally, if it's in the middle, it's less helpful. I just can't necessarily get information. But if it's fat, that gives me a lot of information. And if it's flat, that gives me a lot of information. Now, everybody always wants numbers, so I did include them here. But again, this is just an overall generalization. I certainly would not use 2 as my tried and true cutoff. So here in this picture, this patient actually has the ultrasound in abdominal mode. So our heart's over here on the left side of the screen. This is an example of an IVC. You can see going into the right atrium. Here's the left hepatic vein. And they're saying before inspiration and after. So they're saying it didn't really change much with inspiration. So they're going to say that that's fat, that's bigger. So if we give it numbers, we'll say that IVC is bigger than 2 centimeters and it doesn't collapse with inspiration. So that one we're going to say is fat. Versus down here, we see the IVC going into the right atrium or the heart here. And this IVC is less than 2 centimeters and it does collapse. But really, this is much less than 2 centimeters. If you measured this, I think it would be a lot less. This is a patient performing a sniff test. So that's also why it could be significantly less, but we'll call this one flat. So this one is less likely to have a full tank or more likely to be intravascularly volume depleted. So now that we've talked about IVC use, we're going to talk more specifically about estimation of CVP and prediction of fluid responsiveness, as we talked about. So the first one is going to be estimation of CVP or central venous pressure. And again, this is in spontaneously breathing patients, the echocardiographic measurement. So when we use the IVC to measure CVP, again, this is done in spontaneously breathing patients. So not that we can't do it if they're intubated, but it just is, the literature doesn't support it. They're supine. And the CVP is going to be estimated based on two things. So IVC size, and they use 2.1 as their cutoff, and the decrease in the IVC in diameter with the sniff test. So they ask the patient to breathe in or to sniff a flower, and they say, does it decrease by more than 50% or not when that patient does the sniff test? And it also should be noted that the IVC is commonly dilated in ventilated patients. And so again, it's just not tested in ventilated patients. So I also take that piece of information too, because if my IVC is small in my ventilated patients, then I'm like, ooh, wow, that means a lot to me. That patient is likely, their tank is not full, they're intravascularly volume depleted for sure, without questions, right? But if that IVC is a little dilated and they're ventilated, I might say, well, maybe it's dilated because of the positive pressure ventilation or that increased intrathoracic pressure. And so I might take that with a grain of salt and not take it, just take that into consideration. So again, estimation of CVP is different than fluid responsiveness, and that's going to look at IVC collapsibility and distensibility index. So when we estimate this, we basically say, okay, is the IVC less than or greater than 2.1? So up here, if our IVC is less than 2.1 and it collapses, we say, okay, the pressure is probably 0 to 5. We're going to give it a right atrial pressure of 3. Versus if we're down here at the bottom and the IVC is big, greater than 2.1, and it doesn't collapse, we're going to say CVP is 10 to 20, so we give it a right atrial pressure of 15. If it's any of the combinations, so if it's small, but it doesn't collapse, or it's big, but it does collapse, then we're going to say, okay, 5 to 10, the right atrial pressure is going to be 8. So if you notice on your echo reports, all of the right atrial pressures are going to be 3, 8, or 15. You won't see 7 or 10 or 11, and that's because this is how they do that. So again, we take the IVC diameter and the collapsibility with the sniff test, and we say, is it greater than or less than 2.1? And does it collapse with the sniff test? And therefore, we get a right atrial estimate of 3, 8, or 15. So if you remember, this is right atrial pressure in spontaneously breathing patients. 2.1 centimeters is our cutoff. We want to look, does it collapse more than 50%? And your right atrial pressure will be either 3, 8, or 15. This is just, again, a nice chart that shows the same thing. We start with the diameter. If it's greater than 2.1 and it doesn't collapse, okay, it's got a high CVP, we'll call it 15. If it's small and it does collapse more than 50%, okay, low, we'll call it 3. And then if you're any mix of the two, you're going to end up here in the middle, medium right atrial pressure, we'll call it 8. Now we're going to move on to talk about prediction of fluid responsiveness. So we'll talk about IVC diameter, less than 1.5, likely fluid responsive. Ventilated patients, we're going to use IVC distensibility, and spontaneously breathing patients, we're going to use IVC collapsibility. So this is my all-time favorite fluid resuscitation guide, and this is what I like to follow when assessing my patients for intravascular volume status or fluid responsiveness. And this uses normal IVC as 1.5 to 2.5, which makes sense, right? Because we said when doing CVP, they use 2.1 as their cutoff. I told you generally I use 2-ish as a cutoff, but of course there's a range of normal from 1.5 to 2.5. Now, if it's less than 1.5, then you're going to say your IVC is underfilled. And then this is good literature in both intubated and non-intubated patients. And you can pretty confidently fluid resuscitate your patients and know that you will be improving or likely improving their cardiac output with fluid resuscitation. On the other end, if that IVC is distended and not varying, if it's greater than 2 centimeters, you probably can start fluid restricting, or at least assessing, does my patient have fluid, am I having fluid intolerance, right? Am I having B lines? Am I having some respiratory distress? Am I going to cause this patient harm by continuing to give them fluids? Now, there are exceptions, of course. So elevated right atrial pressure, for example, if you have tamponade, you're still going to give them fluid. If you have pulmonary hypertension that's severe, they may still need fluid. Or if you're looking at this other part, if they have B lines from another etiology, they may still be fluid responsive. But overall, you're going to start to think, am I hurting this patient with fluids? Should I stop with the fluids? Do I need to focus more on my vasoactive agents? Now, if you look down this normal route, 1.9 to 2.5, they have split it up into intubated and non-intubated. And that is because in intubated patients, you use IVC distensibility, which has a little bit better literature supporting it than IVC collapsibility, which is what you use in non-intubated patients. But note that they actually put the collapsibility equation right here. So this equation is wrong. But they're saying if the patient's intubated and they're passively ventilated, right? So they're sedated, they're not triggering the vent, then we can use IVC distensibility, and we can calculate that. And if you get a number that's greater than 12, which we'll talk about in the next slides, you can say that they need to be fluid resuscitated. And if not, you kind of end up over here. But what I generally do for all my patients in this quote normal range is I just go down this non-intubated route and I say, okay, how do their lungs look? Like, how is my patient doing clinically? Do I see mostly A lines or do I see B lines, right? And remember, A lines are those horizontal repeating lines that tell us our lung is well aerated. Our B lines are those vertical lines that go down that tell us our lung is acting like a solid organ. Of course, in this instance, we're assuming that solid organ is pulmonary edema, right? Because we're saying, okay, we need to stop giving them fluid, which is why they note, right, if the B lines are from another etiology, right, they may have interstitial fibrosis and have B lines throughout. That doesn't mean I need to hold my fluid. But then again, if they have A lines, we're going to just fluid test. Maybe we're going to give them some fluid and see how they do. And if they have B lines, then maybe we're going to consider holding. So this is just another picture about M mode or motion mode, putting it over the IVC, and how we would calculate both a minimum and a maximum diameter. You just want to make sure when you do this that you're not sliding off the IVC, you're actually getting that minimum and maximum diameter. So again, overall, the volume status with IVC, if the IVC diameter is less than 1.5, we're good. We know the patient's going to be fluid responsive, and there's good literature in most patients. Versus IVC collapsibility and distensibility. So IVC collapsibility is going to be in non-ventilated patients or spontaneously breathing patients. And here's their equation: the max diameter minus the minimum divided by the mean times 100. Greater than 12 is fluid responsive. IVC distensibility is in our ventilated patients. It's just a slightly different equation. Instead of the mean diameter here in the denominator, we have the minimum diameter. And then greater than 18 is going to be likely fluid responsive. So if I'm ever doing these, I usually just look it up, but I honestly don't do it that frequently. But there are some ultrasounds that will actually calculate it for you, and you just have to put in if the patient's intubated or not. And so if I had that ultrasound, I might do it more frequently. So I think it's helpful to know it exists and know how to do it in case you decide you want to. But again, overall, I can use my IVC as a general gestalt. Is it big? Is it fat? They're probably not going to be fluid responsive. Is it small? Then they are going to be fluid responsive. And again, if it's small, it gives me more information sometimes than if it's bigger, especially if they're intubated, right? Because if it's bigger, it could be because they're intubated, and I may decide to still fluid test. So remember, again, IVC is commonly dilated and may not collapse in patients on ventilators. So while I can say with a lot of confidence when the IVC is small that they will respond to fluid, it's a little harder to say with complete confidence that they won't respond to fluid. And it's not necessarily used to estimate CVP and right atrial pressure if they're ventilated. And again, it's most helpful when small. So again, we've got the fluid resuscitation guide: normal 1.5 to 2.5, underfilled less than 1.5, give them fluid; distended greater than 2.5, try and fluid restrict; And then normal, again, I'm usually going down this route and looking for A lines or B lines, or just looking at the patient clinically. Are they doing fine on room air with A line throughout, or are they on, a lot of oxygen, starting to have some respiratory distress, maybe a little tachypnic? So now we're going to move on to talk about hemodynamic monitoring. So Swan-Ganz catheter or right heart catheterization. So if you remember, here is a PA catheter as we go into the right atrium. Here's our pressure tracing, right? So our normal pressures are about 2 to 6. As we enter that right ventricle, we have an increase in that systolic pressure. So here's your RVSP, or your right ventricular systolic pressure. And I put this in red because this is what we're going to talk about today. This normal pressure is going to be around 15 to 30. Different sources will quote slightly different numbers, but around, whereas that diastolic is still the same. But as you move into that PA, and as you move into that pulmonary artery, you're going to see that RVSP is equal to the PA systolic pressure. It's just that diastolic that increases. And so we're going to use this idea that the RVSP is equal to the PA pressure when we calculate this with ultrasound. And then that diastolic goes up, and then as you wedge, you can also note here that wedge is relatively close to that PA diastolic pressure. So that can also be helpful information if you're following a wedge pressure. All right, so how are we going to estimate pulmonary artery systolic pressure? Well, we just talked about how pulmonary artery systolic pressure is going to be equal to right ventricular systolic pressure. This, of course, is assuming there's no pulmonary stenosis or RV outflow tract obstruction. So how do we then calculate the RVSP, or the right ventricular systolic pressure? Well, the RVSP is going to be equal to the right atrial pressure, so the pressure in this chamber, plus the gradient, or the change in pressure, across these two chambers, across the right atrium and the right ventricle. We're going to get this gradient across the tricuspid valve. This is going to be, again, that change in pressure from the right atrium to the right ventricle. And to do this, we are going to get tricuspid regurgitation. So you do have to have a measurable tricuspid regurgitation to measure a patient's PA systolic pressure. And when we get that tricuspid regurgitation, we're going to use Bernoulli's equation, and we're going to convert that pressure, or that velocity, to a pressure. So if you remember, it's change in pressure equals 4v squared. So our RVSP is going to be equal to 4 times the velocity of the tricuspid regurgitation squared plus the right atrial pressure. And so again, we're going to get that peak tricuspid regurgitant velocity, and then the right atrial pressure, which we just talked about how to get the right atrial pressure, or CVP, based on the IVC. So how are we going to do this? We're going to do continuous wave Doppler across the tricuspid valve. So here's an apical 4-chamber view: left ventricle, left atrium, right atrium. And if you guys remember the talk on continuous wave versus pulse wave, if not, you can go back and listen to my physics lecture. But continuous wave is going to measure all the velocities along this line, but it won't tell you where they're coming from. Well, if I'm looking for regurgitation, or the fastest velocity, right, I know that that's going to be across my valve at the smallest orifice is where I know my max velocity is going to be. Pulse wave Doppler is going to measure the velocity of blood at one specific location. So I'm going to put my continuous wave Doppler across the tricuspid valve. I'm looking at tricuspid regurgitation. So I'm looking at blood that goes back into the right atrium during systole. And that blood is going away from my transducer. So it's going to be a negative Doppler shift. So I can move my line up a little bit, anticipating that I'll get this negative Doppler shift, or this filled in hole here. And this, we usually don't have EKG leads hooked up in POCUS, right? But if you did, right, you'd see that this is during systole or during your QRS. And then when you get that max velocity, the computer will actually use Bernoulli's equation for you to change that pressure gradient, to obtain, that pressure gradient between the right atrium and the right ventricle based on that velocity you found. So you would take your little cursor, you'd put it here at the max velocity, and the computer will tell you that change in pressure. And then you would add that change in pressure to the right atrial pressure. If the patient's ventilated, maybe you can get a CVP off a central line, or you can kind of type in different CVP examples and see, or you can do your IVC and hope that it's somewhat accurate. And again, once you add this change in pressure to the right atrial pressure, you'll get your RVSP, which if you don't have any pulmonic stenosis or RVOT obstruction, that is going to be your PA pressure. So again, your RVSP is going to be that change in pressure, so that velocity squared times 4, the computer will calculate it, plus your right atrial pressure. So again, in estimating PA systolic pressure, you're going to put continuous wave Doppler across the tricuspid valve. That's going to give you that tricuspid regurgitation max velocity. Bernoulli's equation will give you that change in pressure from the velocity, and you'll add that change in pressure to the right atrial pressure, and that'll give you your RVSP. And then if you have no severe stenosis or RV outflow tract obstruction, that RVSP is going to equal that PA systolic pressure. So here's an apical 4-chamber view, LV, RV, LA, RA. First, they put color Doppler across the valve to kind of see where that blood is going, right? Because sometimes it's hard to find that actual tricuspid regurgitation, especially if it's small. So you can put color Doppler to see that location of the jet. Then you can put continuous wave Doppler across the tricuspid valve, across that jet, kind of going where that, you see the blue down here, that's where that blood is regurgitating back into the right atrium. You're going to have continuous wave Doppler, and then that will find the fastest jet. So again, we said this is a negative Doppler shift, blood going away from my transducer. It should look like this, kind of like a hill. It should be filled in here if you have a nice tracing. And then you're going to move this little plus sign here to the maximum velocity. So this is velocity over time. So time is on my x-axis, velocity is on my y. So here's that velocity right here, -4, negative being because it's going away from my transducer, a negative Doppler shift. So here's my velocity, 4.04 meters per second. As I said, the computer will calculate what that change in pressure is for you. And then we would plug that into this equation here. So 65 is our pressure gradient plus our right atrial pressure. So we can get it again any other ways discussed, or you can just pick a middle ground 8 to get a roundabout number. And now that we see our PA pressure is 73. So we know that's significantly elevated. This is just showing all the cuts through the short axis view of the heart. So our typical POCUS view is going to be kind of right here between B and C, or just past the level of the mitral valve. But notice that you're up here, if you're up here at A, that's going to be that parasternal short axis AV view, aortic valve view, or sometimes we call it the RV inflow outflow view. So here's your aortic valve and short axis view. Here's your right ventricle. Here's the inflow. So here's your tricuspid valve. Here's your pulmonic valve. Here's your PA. So the blood goes in and out of the right ventricle. And here's just another place that you can look for tricuspid regurgitation across that tricuspid valve. So here is measuring the TR jet in an RV inflow outflow view. Here's that aortic valve and short axis view, the right ventricle on the top of the screen, left atrium on the bottom of the screen. Of course, if you were in transesophageal echo, note for your boards, right, that it would be swapped and the left atrium would be on the top and the right ventricle on the bottom. So that's going to put your tricuspid valve over here, and here we have continuous wave Doppler across the tricuspid valve to look at tricuspid regurgitation max velocity. So again, we said right ventricular systolic pressure, or RVSP, is a surrogate of PA pressure. It does require a TR jet. So if the patient doesn't have any tricuspid regurgitation, unfortunately, we can't calculate it. We are going to use simplified Bernoulli's equation to convert velocity to pressure. And again, you don't need to know the equation, but it is change in pressure equals 4V squared. So just knowing that it uses that velocity. And then you're going to add this change in pressure to the right atrial pressure to give you that PA pressure, or that RVSP. And then this is just kind of a cutoff I have in my mind, that if that velocity is greater than 2.8, we already know that we're going to have an elevated PA pressure. Even assuming the right atrial pressure is 3 to 5, you're already getting greater than 36. Now we're going to talk briefly about left ventricular end diastolic size as a potential marker of preload. So end diastolic size of the left ventricle kind of determines the strain of the fibers before systolic contraction, and it can represent the LV preload. It's not a great indicator, but some studies do show that the diameter or the area or the volumes can be indicators of preload. When we measure this, we'd want to measure at the level of the papillary muscles, so that mid-ventricular short axis view or long axis view, but kind of at that level just past the mitral valve. And then again, it doesn't always correlate with fluid responsiveness. So sometimes it can be helpful, but not always. So here is a short axis view of the left ventricle. Here's that circular left ventricle, the crest-centric right. This is measuring the diameter. Here it's 3.86. It's hard because normal is quite a wide range of normal, so 3.5 to 5.4. So again, not always helpful, but sometimes if I have an end diastolic diameter of 3.1, it just, and the IVC is small, it kind of puts together the whole picture for me. Just one more piece of information. Here's where you would measure in the long axis view. This is the parasternal long axis view: right ventricle, left atrium, mitral valve, LVOT, aortic valve, ascending aorta, and here's the distance in diameter here. So fluid assessment and LVADs, I know in the CT-ICU, you guys are often seeing LVADs, and this is one patient population where you would be particularly interested in assessing their fluid status. Of course, we can look at ultrasound or transthoracic echo. We can look at the size of the IVC. Is it dilated? Does it have respiratory variation? Of course, if it's dilated and doesn't vary a lot with respiration, that might suggest that they're volume overloaded. We can look at the size of the left ventricle. If it's dilated, that suggests fluid overload. I think this can be more helpful in LVAD patients than in other patients because they have frequent echoes. And so it's pretty easy to look back on their last echo and see what their last diameter was. And then you can kind of say, oh, it's a lot bigger, so maybe I need to diurese them, or oh, it's a lot smaller, maybe they're bleeding. And again, small and underfilled would suggest that the patient's dry. BNP, of course, is sensitive but not specific. And then we have our LVAD parameters. So for the HeartMate 2, our pulsatility index, if it's high, that can suggest that they're volume overload. If you have an HVAD, you can evaluate that waveform. And if they have high pulsatility, that can suggest that there's volume overload or hypertension. The HeartMate 3, and I know we're seeing more and more of them, the PI is a little more difficult to interpret. And of course, right heart catheterization is commonly used. However, we've kind of just gone through how we can use our ultrasound to get a lot of the numbers that we would get from a right heart catheterization. So hopefully we can avoid unnecessary procedures and get some of that information from ultrasound to help us assess our patients. If they're volume overloaded, again, we can diurese them, or their cardiology team may decide to increase the speed or RPMs. This is a chart showing the common postoperative hemodynamic scenarios and suggested management strategies. So this can be helpful, of course, in the CT-ICU if you have a patient post-op. So if we look at our echo findings for hypovolemia, again, we might see a decreased LV diameter, or you can also look at that aortic valve. And if it's not opening, it could suggest that there's not enough volume, or that the LVAD is taking off more volume than it should be, or that the patient needs to have more volume. For RV failure, of course, you may see a dilated right ventricle, or the septum, the LV septum might be shifted to the left, and you have an underfilled LV depending on the extent of it. Tamponade, I always think it's important to note that a circumferential effusion is not required in post-cardiac surgery patients. So if you're training your eye to look just at the anterior wall, you may not see significant tamponade, but there could still be a posterior effusion. So be careful to rule it out, or to not appropriately or prematurely rule it out when you're looking for tamponade. And then systemic hypertension, of course, your echo findings are going to be typically normal. And then after all that, what test of fluid responsiveness is best? And the answer is going to be the performance of a passive leg raise. So this is from JAMA, a meta-analysis of 50 studies. I think there was also one recently too in intensive care medicine. And it basically says that the change in cardiac output following passive leg raise appears to be the most accurate predictor of fluid responsiveness and can be used independent of ventilation in most. And so again, it says cardiac output, which a lot of times we look at blood pressure. So I would challenge you to say, okay, if we're going to do a passive leg raise, let's actually look at the cardiac output by ultrasound, which we talked about in the last lecture on global LV function, where you put the pulse wave Doppler in the LVOT and actually get that VTI, LVOT VTI to correlate with that cardiac output. But the passive leg raise does appear to be the most accurate predictor of fluid responsiveness.